Hi all, welcome to our SEMET and US April Prime session. Just to give a brief overview, because I believe we have participants from all around the world, and some of you might just be joining our Prime session for the first time. So NUS Prime sessions serve as a monthly platform for researchers like you who are involved in health professions education projects. So you could present your research finding to a wider communities here. And we do have educators and researchers from around the world to listen to your proposals and receive feedback on to improve your proposals or your ideas. If you have some research ideas that you want to receive some feedback, especially from the perspective of methodological advice, you could also share your project in NUS Prime. So we have this session monthly on the first Monday of each month from 12:30 to 1:30 p.m. So today, similarly, we have two presenters. Okay, I'm going to introduce you the first presenters, who is from the Department of Emergency Medicine, Chang Memorial Hospital, Taiwan, Dr. Shu-Chen. So Dr. Shu-Chen currently is an associate professor at Chang University. And she specialized in emergency medicine, toxicology, simulation, and medical education. So today, she's going to share with us augmented reality visualization for ultrasound-guided intervention. So I would like to invite Dr. Liao to share about her research project. Dr. Liao, over to you.
Okay, thank you everyone. And I will start to share my study. Okay. Wait one moment. I'm not so familiar with this. So okay. Okay. Okay.
All right.
See?
Yes.
Okay. Okay.
Yeah.
Hello, everyone. I'm Dr. Shu-Chen Liao from Taiwan, and the biggest hospital in Taiwan, Chang Memorial Hospital. Today, I would like to share and discuss my research on applying augmented reality to invasive clinical procedures. This research was supported by the Taiwan National Science and Technology Council 2021. The title of the project, as you see, is the Augmented Reality Visualization for Ultrasound-guided Intervention. It is a pilot randomized crossover trial to assess the training performance and cognitive load. I think you know what is augmented reality. I believe most of you are already familiar with it. AR, or augmented reality, refers to overlaying virtual images or information onto the real world. It's just like the Pokemon Go game, where virtual creatures appears in your real world environments. So it's a very popular game. But although AR technology has been widely applied in entertainment industry, such as video, games, media, and broadcasting, its practical application in the field of medicine is still in its early stage. How early? Just like in fact, in the real world, the application of AR in the medical field or medical education is very rare, just like an oasis in the desert. So we aim to develop a basic AR application for invasive vascular access procedures, hoping it could serve as a starting point to inspire further exploring in this road. The purpose of our study is we know AR using a head-mounted display to guide invasive procedure is a underexplored technology in medical education. This study investigates the performance and the cognitive load of physicians in ultrasound-guided central venous catheter placing using AR HMD ultrasound, also named as AR ultrasound, or compare with the standard ultrasound without visual overlay, also as the standard ultrasound. We enrolled 47 participants, 22 clerks, 25 postgraduate year 1 to 4, 15 women, 32 men in 2021 to 2022. These trainees had complete basic ultrasound-guided CVC placement training, but they lacked AR ultrasound. They lacked the AR ultrasound experience. We want to examine the AR ultrasound effects, so we designed a randomized crossover study. Participants perform both ultrasounds, AR ultrasound and standard ultrasound guided CVC placements in random order. Data recorded including time with ultrasound for vessel identification and puncture guidance, procedure time without ultrasound, puncture attempt, first pass rate, frequency of visual focus shift from ultrasound display to simulator, and NASA test load index. Here is the study flow charts. There are 47 trainees. First, they complete the basic information questionnaires and written a pre-test. There are 10 multiple choice questions and random assigned. So if one trainee is assigned first to the standard ultrasound group, and he or she perform the ultrasound guide CVC placement first, and after that, he or she fill out the NASA test load index, and we record the performance time in each step, and he fill out the NASA test load index questionnaire, and after 10 minutes rest, and he shift to the AR ultrasound group, and we record every steps every step he requests the required time in each steps and the performance, and after the perform of the CVC, he fill out the NASA test load index questionnaires, and we analyze all the data. So here is the crossover study. So we only have 47 participants in this study. There are three photographs. A is the trainees. She is perform the ultrasound guide CVC placement. As you can see, she wear the HMD, the hand mount device, but she didn't need to check the screen because the ultrasound image is transferred to his glass. The upper parts of the glass is the ultrasound image. The lower parts, she can see through the environment, and she can see everything in the environments, and including the simulator or the patient. So we only transfer the image to her glass, the upper parts. So just like the augmented is the augmented reality means. So we transfer, it's a basic AR use. So we transfer the image to the upper parts of the glass. And so the trainees can see the patient or the simulator and the ultrasound in the same field. Here is the results. We compare the performance of the participants' ultrasound-guided invasive procedure skill in the standard ultrasound and the AR ultrasound groups. We separate to the T1, T2, TU, and TNU the time. The trainees take the time. The T1 means the time taken to use the ultrasound to identify the anatomy of the insertion sites and locate the vessel. It's an internal jugular vein. The T2 means the time taken to use real-time ultrasound guidance to puncture the internal jugular vein with the CVC syringe and obtain the venous flashback. The TU is the T1 plus T2. The TNU means the procedure did not need the ultrasound help. So the other time he or she complete the procedure. Here we can see if we compare all the trainees, the AR group and the standard group, there are no difference in the performance time. So maybe they take less time to identify the vessel, but it's no significant effect. Figure 4 is the scoring system. It's to evaluate the performance the trainees need help or not. So the same, the blue bar is the AR group. The red bar is the standard group. So here we can see from the ultrasound guide help. So there are maybe 6 steps need ultrasound help. It include the vessel identification, needle puncture along probe axis, needle visualization, needle tip visualization, internal jugular vein puncture with venous return, and guide insertion. There are 6 steps need ultrasound guide. Here we can see the red bar is the standard group. They need more help from the instructor, even though it's the verbal instruction or hands-on instruction. So if you have the AR device, so you need less help, the blue bar, from the instructor. Figure 5 compare the NASA text load between the AR group and the standard ultrasound group. Here, the NASA text load with 6 dimensions is mental demand, physical demand, temporal demand, performance demand, efforts, and frustration. Here we see there is no difference between the AR group and the standard ultrasound group. But if we look at the subgroup, we separate the different scenario. We have the UGY trainees and the PGY trainees. If we only, the subgroup is the UGY trainees. So here we can see in the NASA text load, there are differences in the efforts. If you use the AR device, there are less efforts in the AR device group trainees and the less frustration. So the UGY trainees, when they use the AR device, they feel less effort and less frustration. But the phenomenon we didn't find in the PGY group. And here is also the subgroup analysis in different genders. Here, the same, we see the NASA text load. This is the female group. And here we can see in the female group, we can see the blue bar. The blue bar is AR device. They also feel less efforts than the standard ultrasound group. So the female trainees, when they use the AR device, to do the CVC placements, they feel less efforts than the standard ultrasound. But the situation did not found in the male participants. Here is also the subgroup analysis. So now we can see the performance. When we compare the female and the male in the AR ultrasound, we can see they also use the use the AR device. But the female trainees, female participants, they spend less time to find the location and to have less time to identify the target vessel. So they spend less time to have the identification of the anatomy than their male participants, than their male trainees. And but the situation did not see in the standard ultrasound group. So when the female trainees, they have the AR device, they spend less time and they have quick to identify the location of the target vessel than their male trainees. Here is the subgroup in the NASA text note. We compare the female and the male. So here is the AR group. There are no difference from the male and the female. But here is the standard ultrasound group. You can see the female is the orange bar. They have, when they use the standard ultrasound to have the procedure, they have more efforts than their male trainees. So there are no difference in all trainees, but in the subgroup analysis, we can see some groups have some benefit from the AR device. Here is the discussion. This study is the first study to have the investigate skills acquisition of trainees apply AR technology in ultrasound-guided intervention of CVC placements. We examined the effectiveness of AR by evaluating trainees' performance and the cognitive load. We found something that AR technology reduce time required for critical steps, and they need less help from the instructors. They minimize neck strain for users and assist trainees performing ultrasound-guided CVC placements. The AR technology reduce the trainees' dependence on instructor assistance. Furthermore, participants perceive lower mental and physical burdens using AR ultrasound compared to standard ultrasound to achieve the same performance level. In the subgroup, we found that especially the AR technology may benefit for the junior and female trainees, suggest that AR technology may be useful to enhance the junior trainees in the medical training in the field of CVC placement. Cognitive load theory distinguishes between intrinsic externals and the germ cognitive load. When cognitive load exceeds working memory capacity, learning and performance may suffer. AR technology reduces the external load by integrating the ultrasound image and the simulator into the same field of view. As they combine the surgical field and the trainee's visual field, thereby reducing the real-time amount of information in working memory and enhance trainees' performance in CVC placement. Conclusion, we found that using AR technology helps improve the participants' performance and reduce cognitive load in ultrasound-guided intervention for the vascular puncture for the CVC placements. Placing the ultrasound image in the operator's line of sight through AR reduce external cognitive load by improving trainees' spatial perception and reduce overall intervention time by integrating the surgical and the visual field in the same field. This study provides fundamental grounds for the utilization of AR technology to enhance physicians' learning in ultrasound-guided intervention procedures. There are several limitations of this study. The target of the ultrasound-guided intervention in this study was a simulator, but not a patient. Simulators do not have anatomy variation like real human. The second, the practitioners enrolled in this study did not have experience with AR head-mount device experience. The third, we did not distinguish between participants who have prior experience using AR terminal device, like such a smartphone, AR, tablets, smart glasses, and AR headsets. We did not distinguish between the participants have this experience, so maybe they are familiar with the AR device or they are less familiar with the device. So in this study, we did not distinguish in this one. So here is our study, and thank you for your listening.
Thanks, Professor Liao, for your very interesting study. Let me see in the chat whether we have any questions. Not at the moment. So I have a few questions for Professor Liao with regards to these studies, because I see a lot of subgroup that you have done, and it's quite interesting to see that the effort and the frustration between undergrad and postgrad, there's a distinct difference, and male, female, there's a distinct difference as well. Can I ask whether have the team investigated why undergrad students will have more frustration when dealing with the standard simulation as compared to AR simulation?
I think the younger trainees, they are familiar with this technology more than the senior trainees. They love the technology. So when they use this device, they are very happy and they are satisfied, very happy to use this device. And I think maybe because we don't distinguish the experience, the AR or VR or any XR device use. So I think maybe they had used the experience to use this device, and they feel very happy and they are enjoying the test. So I think that's the reason why they feel less frustration and less effort. And the female trainees, they have a very interesting finding that the female trainees, they can find the target vessel quickly when they have the device. So I found many literature. I have research on the literature why have this phenomenon. So I found one theory to support. It's a Hunter and Gary theory, because in the old, very hundreds years ago, the male is a response to hunting. They hunting and they have they kill the animal and they hunt. They hunting is their jobs. But for the female, they are response to have maybe find some food around their in the environments, and they gather the foods by locates. They know the locates where is the food, and so I think maybe the evolution of the human. So if there is a hunter and gatherer theory, maybe can explain the phenomenon.
Perhaps it will be an interesting area to investigate further as well. Because I'm quite interested to see the difference between female and male in using AR and the standard simulation. So have you all tried out in other topics as well?
Pardon?
Have you all tried out on other topics? Because this is mainly on the ultrasound-guided intervention.
Because I think my research is focused on AR, VR, XR. And I think AR is more suitable for the medical education because as a doctor, you need to touch the patient, you need to feel the patient, and you cannot, the environment is real. So the VR is virtual. You cannot touch, you cannot feel anything. But the AR is you can see through you can see the outside environments and you can touch the patient. So I think the AR is more suitable for the medical education in the real world. And the ultrasound that we transfer the ultrasound to the glass is the first step to in this study. The next step we will we will use the ultrasound in the real patient because the device is approved by the medical field. So next step, we will have the AR device to the real patient in the any vessel puncture steps.
All right. There's a question, I think it's related, coming in the chat. Okay, one of the question is, I'll read two questions together because I think it's related. So what are your plans to investigate this further? And will the team be investigating, for example, the CVC location challenges different between the male and female patient?
My next steps research is use the AR to the real patient.
Okay.
And the male and female,
Patient.
because we only have 47 participants in this study. So I think there is a trend different from the different gender and different seniority. But I think I need more participants to have the scientific maybe the specific power to approve the results. So the next step is to using the real patient, and we will enroll more and more. Maybe 47 is not enough. So maybe the next step is more participants in this study.
I see. Okay. Then can I also ask what changes were made to the teaching after your research? Can you share a little bit on this?
Why I adapt this research, because we know ultrasound is very popular in the medical field or medical education, but for the junior trainees, it's a challenge. The ultrasound, you need to learn the ultrasound first, and you need to read. You need to identify the anatomy in the ultrasound, and then you should check the patient location from the body of the location. And so it's too busy for these junior trainees because I see the challenge for the junior. So I adapt this study for them because I think maybe we can combine the two field in the same, the visual field and the surgical field in the same field.
Yeah.
It's maybe benefit for these junior trainees. But I think for the senior trainees, there are no benefit, I guess, because they are so familiar with the ultrasound use and so familiar with the variation of the anatomy, anything like that. So I think this study is a benefit for the junior, not for the senior.
Okay.
But it surprised me. It's a benefit for the female.
Yeah.
It's surprised me. The result surprised me.
So is Chang Medical University going to change from the standard simulation to AR simulation after your study, or what are the plans for Changdong?
Yes, we will adapt the AR to the real patient. And for the students, for the undergraduate students, I introduce the device to them and only in the simulation room. But after the study, we will adapt AR to the real patient. It's the difference.
Okay, all right. Thank you so much, Professor Liao, for your sharing as well as answering all the questions. I don't have any questions anymore. And I believe for those who are involved in simulation or AR simulation, if you have any question, do always drop an email to Professor Liao. And we hope to see more interesting studies coming from your area as well, and to enrich our view about this AR simulation and cognitive load. So I would like to invite my colleague next, Dr. Jillian Yu, to introduce the second speaker. And thank you to you, Professor Liao.
Thank you.
Thank you, Professor Liao and Shu-Chen. So right now I'll introduce our second speaker. So our second speaker is Dr. Mariko Morishita. She's from the Department of Patient Safety at Kyoto University Hospital in Japan. So today, Dr. Morishita will be sharing with us on exploring the history of medical education through narratives from alumni at the Faculty of Medicine in Japan. So I'll hand it over to you.
Thank you. So now I'm sharing my slide. Can you see the slide now?
Yes. Can you put it in presenter mode?
Yes.
All right. Thank you.
Okay. So wait for a moment. So hello, I'm Mariko Morishita, working in the Department of Patient Safety, Kyoto University Hospital, and I'm also a member of Historical Archives of Graduate School of Medicine and the Faculty of Medicine, Kyoto University, Japan. Thank you for giving me this opportunity to present our project exploring the history of medical education through narratives from alumni at the Faculty of Medicine in Japan. So today, I'm going to talk along with this plan. So first, I introduce the process of my involvement in this project, experiencing the production of a museum exhibition. I'm not a historian, but an educational scholar and a family physician. Therefore, I'd like to explain why I started this history project with collaborators, including museum archivists, academic content designers, pathologists, and medical educationists. Second, I situate this project in previous research on the history of medical education in Japan. This project doesn't rely on historical documents, but on lively narratives from graduates. Therefore, we chose oral history as our methodology, collecting narratives of each graduate experience. Then I'm raising some examples of the narratives from the graduate, showing how medical education in the past, especially in 1960s, was like. Then, while collecting the narratives, we preserved the past educational materials, including wall chart for anatomy. I'm going to introduce this activity as well. And finally, this project, of course, has some limitations and needs further study. So after sharing this project, I'm happy to receive comments and questions from you, the audience. So first, let me introduce why I was involved in this history project. So this is a flyer for the museum exhibition held in 2021. This exhibition's title was Becoming a Doctor, Medical Education at Kyoto University. In 2018, when I was a PhD candidate at the Medical Education Center, I was asked to join the committee to prepare for an exhibition on the history of medical education. Because I was interested in history, I agreed to join the committee. That was the beginning of my involvement. In this exhibition, we put both old educational tools, such as wall chart and skin moulages, that are skin models, and contemporary educational tools, such as CT images and simulators. Through creating a plan for the exhibition, we had a question in our minds by comparing educational material from the past with those from the present. What could we consider for the future of medical education? For example, at the exhibition, we compared skin models with simulators. Figure 1 shows a skin model representing skin tuberculosis. The Department of Dermatology created this moulage, collaborating with technicians unknown. Their object for obtaining medical knowledge when photographs were not common. Figure 3 shows that simulators have been exhibited. In contrast to the skin model, simulators allow students to actively learn medical skills and knowledge. Presently, students must engage in simulations before encountering patients. Comparing the two kinds of materials, we went back and forth from the past to the present and could consider how medical education has been changing. So at the exhibition, we made other comparisons. One was a comparison among different types of medical training and narratives from graduates. As you might see, there are 3 different types of physicians training system in Japan. we presumed that student experiences could differ depending on which training system they needed to get in. Therefore, we attempted to understand the relationship between the type of training system and graduate narratives. This is an origin of our present project, collecting narratives from graduate. We set 3 phases with different types of training systems. The first was the internship training system, which started in 1946, ended in 1967. In this system, graduates needed a 1-year training to take the national examination for a doctor's license. In the second system, we usually call it a straight training system from 1968 to 2003. The graduate went directly into a specialty training course. This means that graduate could belong to any specialist department immediately after passing the national examination. Since 2004, basic 2-year clinical training system has been implemented. After the graduate are required to rotate several areas, such as internal medicine, pediatrics, and surgery, instead of belonging to any specialty department. Besides these changes, the medical educational curriculum has become rigorous, which means that the standardization of medical education has progressed. The background situation transformed significantly as well in the 20th and 21st century. Medical knowledge has expanded and technology has been developed drastically. Through analysis, and analyzing the collected narratives, we thought that what narrative could show that being a doctor doesn't simply mean becoming a doctor practicing clinical medicine, but providing education for the new generation of doctors, reforming medicine itself with new discoveries through research, and contributing with findings to create our society. This idea has motivated us to continue the project to collect narratives from graduates. So to begin with, why would we like to consider history? According to Chizuka, a Japanese historian studied French Revolution, there are 3 aims to look at and investigate history. First, researchers and people think that history is an interesting topic. Focusing on historical figures and events is interesting because it allows us to extend our knowledge and experience. The second aim is to objectify the present situation. It is a history for reflection. Knowing historical context, events, and people's interactions, we can relativize our present situation. The third aim is to objectify the present and predict the future. The idea is derived from the idea of history as a development. It is assumed that by considering the causes and effects in history, we might be able to predict our future. This is not always the case, but history might provide us with some clues to consider the unpredictable future. Therefore, there may be reasons why we'd like to learn past medical education. When we try to understand and criticize the present situation, we might need to relativize our situations, comparing with those in the past. With these perspectives, let's look at the previous studies on the history of medical education in Japan, for example. There have been studies on the number of medical schools and system development. These studies elucidated the relationships between medical schools establishment on the left-hand side and governmental system development on the right. Other previous studies have shown that the curriculum of Tokyo Imperial University, the first Japanese national university founded in 1886, scholars have investigated whether the curriculum is similar to that of German Army Medical School. The other areas of study are about medical teachers from overseas in the Meiji period. For example, the figures studied are Dr. Julius Karlskriber, Dr. Erwin von Belz. They are German doctors who taught medical students at the Tokyo Imperial University. From these previous studies, we are able to know how the system and curriculum were developed and who were the leading medical educators in the 19th century in Japan. However, their primary source is a document from governmental offices and universities, or from the doctor's diaries, and the areas of study are limited to system and structures of medical education, rather than student learning experiences. Therefore, what and how students learned medicine in the past is unclear. To elucidate and explore the individual experiences, we may need to collect student narratives. So, having outlined the project background objectives, let us now delve into the methodology employed, specifically our choice of oral history. Collecting narratives about the past is known as methodology, oral history. According to the Associations of Oral History in Japan, oral history has developed dramatically in Europe, the US, and other countries, and its value is now widely recognized. So they are also being used in the public. Japanese academics has traditions of collecting story from people, which is called writing based on listening and life history. Unfortunately, because of diversity in quality and method, the value of information and record gathered orally has not been well received by those who value the written record. Towards the oral history, there are typical critiques. A story is narrated by people too subjective. A story is narrated by people's memories factual. When we would like to clarify how people experienced the past event, we need to ask them about their experiences. However, we might not verify whether the stories narrated were fact or not. Therefore, we could say that oral recollections cannot be called fact. We might somehow need to collect historical fact or evidence from written records or common memories by other people. So in our project for collecting the narratives from the graduate, interviewees were recruited by small snowball sampling. Semi-structured interviews were conducted. The questions are, tell us your career history from the time when you graduated to the present. What was the most impressive classes during the 6 years in the Faculty of Medicine? How did you spend your school days? All interviews were recorded and filmed. In this presentation, I picked up some sentences showing transformations of medical education and unchanged areas, focusing on the part in the interviews. So here is the information about the participant in our project and the museum exhibition. This project is ongoing, therefore, this is the interim result. For the first period from 1946 to 1967, we interviewed 3 graduates. For the second, we interviewed 9, and for the third, the most recent period, we interviewed 6. The black numbers represent the number of participants in this project, not for the museum exhibition. In this presentation, I'm going to pick up the narratives from the graduate in the first period. So this is the curriculum speculated from the graduate narratives. After graduating from high school, they passed the entrance exam and went into a 2-year liberal arts course. They then proceeded to the basic medicine course, including anatomy, histology, biochemistry, and so on. In the next step, they went to a clinical medicine course and clerkship called Polyclinic, which is a German word. After these, they took the examination for graduation, and after graduating from school, they joined 1-year internship training program before taking the national exam. So for anonymization, I call 2 graduates, B and C, both in their 80s. These are narratives of the course on anatomy from B and C. Interestingly, B noted that it was a passing point to become a doctor and remembered the anatomy course well. However, another one, C, didn't for some reasons. B noted, in the anatomy practice, students were divided into groups of 4. They surrounded the body from each side, right and left. The anatomy course was a passing point to become a doctor. Since we handled corpses, we wore gloves, but the gloves were reused permanently. He clearly remembered how he handled even gloves that might not have been disposable. In terms of attitude toward the another interviewee, C, mentioned the anatomy course differently. I don't remember much about how the anatomical practice was done. My father was a surgeon, so I often saw trauma patients brought to my father's hospital. People involved in car accident also came in. Therefore, I was used to observe the injuries and blood. So perhaps I didn't think anything of it when I saw the corpses in front of me. I don't remember much about the gloves either. He noted that when he became a doctor in the 1960s, the number of car accidents increased. Throughout their learning medicine, their visual objects, drawings may have maintained an important position in medical education. C commented the drawing teacher library painted on a blackboard. What impressed me in the lecture was the brilliant blackboard drawings by the anatomy professor. I remember admiring those drawings as he drew the nerve pathway neatly on the blackboard with chalk. They spoke about classes that were not good in their memories. C noted, I remember that a biochemistry class provided the latest findings and I didn't understand those well. On the contrary, B mentioned that he preferred the discoveries. I thought that lectures that contained facts were not very good. I enjoy reading books written by a current Nobel Prize laureate, including their latest findings. Even though teachers provided the latest findings, some students might have enjoyed it and others didn't. Interviewee B chose to become a researcher for biomedical research, and the interviewee C chose to become a clinician researcher. Their interests might be related to their career choices when they're reflected on their past. In the clinical lectures, the patient was accompanied by a doctor in a classroom. This picture shows how the clinical lecture was provided in a classroom in 1915. The time is different from that of the interviewee C, but C could have experienced a similar lecture. He noted, the clinical lecture was a joint class for 2 grades. The number of students was large only at the beginning and then became increasingly smaller. Patients came to the class with an assistant, so I think the doctor in charge of the attending doctor accompanied the patient. The patients were brought to the classroom on stretchers, and the student watched them from above in the stairwell classroom. Students heard and read several languages classrooms. B remembered, teachers usually spoke German for their lectures. I strive to learn Latin. English is a commonly used language. I remember that German and Japanese words were hard in the classroom. I do not remember whether the French was heard of. I might have read Maupassant's work and others during my liberal arts course, but I have already forgotten it. I might have read French in neurology. From his comment on the languages, German, Latin, English, and Japanese were the languages medical students needed to learn, which is different from that in the present. So far, I have shown the tentative result of our project by collecting narratives from the graduates. Through these narratives, we might be able to consider how context, educational environment, and language influence student learning experiences. Of course, we can examine other elements as well, but in this presentation, I discuss these issues. So context, such as economic growth, industrial development, and car accident may be related to specializations in medicine. Surgeries were divided into several areas such as neurosurgery, cardiovascular surgery, and transplant surgery. Molecular biology has also been well established. These new discoveries might have been fascinating for medical students. Regarding in the classroom and with educational materials, the style of clinical lectures didn't change, and there were pictures on the blackboard, which were observed in traditional medical education. New things were also provided to students. For example, teachers delivered the latest findings in the classroom and printed photos in textbooks. With regard to the language used in medical education, there was a transition from German to English. According to interviewee B, Latin words were still used, but English became a common language in learning medicine. So briefly, I'd like to focus on education material from the past as well, including wall chart for anatomy. They were probably drawn before World War II. The interviewees in this project didn't remember the wall chart or scenes used in the classroom. Although we collected narrative from the graduate as far as they were well, we have limitations. Considering past medical education, our project preserved these materials. In sum, what can we learn from history? Several questions emerged from our analysis. As mentioned above, medical specialization has been responding to the time. At present, how do we try to create new divisions for new social requirements? Simulators and digitalized educational materials might be useful and time-sparing, and the patients are no longer exposed to the classroom. How do these tools make education different? So we do not use German or Latin in learning medicine. We use Japanese and English mainly in Japanese medical education. What does the standardizations and globalization of medical education mean to each local educational environment? There are, of course, some limitations in this project. The number of the participants is still small. We feel the shortages of information about the curriculum at the time, and there is a lack analysis with influence of other historical events, such as the student activism in 1960s in Japan. For further study, we may be able to align with other narratives in other times. Then we could explore the transformation of medical education, especially when we focus on transitional period from the previous system to the new one. So these are concluding remarks. Individual experiences are unique and interesting to know what we couldn't experience in the present. The oral history of medical education could provide us questions to be asked for developing the future education. We might be able to consider meanings of specialization, digitalizations, and globalization. And let's consider and preserve historical materials on oral history of medical education. That's all of my presentation. Thank you for listening.
Thank you. Thank you, Dr. Morishita, for your sharing. It's a really unique study with a unique methodology that you have chosen. So for our participants here today, if you have any questions, do feel free to put them in the chat. But in the meantime, I have a question for Dr. Morishita. Given that there were the findings that you have shared about from interviewing your the clinicians that you had interviewed, are there particular elements that you will be changing or will be adopting to the new curriculum?
It's a really difficult question, but so I think that, for example, the drawing is one of the traditional methods that the medical educator used in the past, and nowadays the medical teachers usually use PowerPoint presentation to let students know what they are trying to teach them about, for example, the anatomy. But the drawing tradition might be really interesting, and I would like to preserve that tradition if it is possible. And
Yes.
I'm not sure how the drawing could influence the student learning and also the teachers, but that may be the beautiful tradition, I think.
Yeah. Agree. I think most anatomy books first began with actual drawings. So, and I think that was the beauty of medicine at a point of time. So moving forward, perhaps we will find out more about in your future research if you choose to include any of these into your new teaching. Okay. We have a question from Pei-Chin Chua. What were some of the teaching elements which clinicians feel will be non-negotiable regardless of time and
Will be non-negotiable. What do you mean by non-negotiable?
non-negotiable means they feel it's something that must be part of the teaching, something that they feel cannot be removed.
So as you might have seen, the digitalization, we cannot stop the digitalization anymore, and the content of medicine also has been changing a lot. And as I have shown, the molecular biology is one of the new areas in the past, but nowadays this is the main topic that we should learn. So we need to change our topics that we focused on in medical education, but at the same time, the anatomy, for example, is one of the basic elements when we learn medicines. And when we learn anatomy, we can understand the whole structures of our body. That is one of the topics that we must learn and understand deeply, more and more. Maybe the combining with other areas of study like molecular biology and maybe the new emerging areas.
Thank you. So fundamentally, I think what you shared is that anatomy still remains key, but then with the changing times, new technology that can be added on to this basic information, knowledge that we need to know.
Yeah.
We have a question from Shu-Chen. Shu-Chen asks, do you have students who do not appreciate this method?
This method, do you mean this method is oral history or?
Shu-Chen, will you be able to clarify what you mean by this method?
The teaching method using narrative and with combining with the topic itself.
So do you mean that the teaching method could be combined with new emerging method or?
Oh, no. Because you share that you are integrating medical education topic within whatever that you all are teaching, right?
Mm-hmm.
Yeah. So do you have students who felt that it's not so important for them? Yeah, and they feel like they would like to learn more clinical related topics. Yeah.
Yeah. That's a great question. And I think the history is really difficult topic, especially for younger generation, because they are not interested in old things. They might not be interested in old things and history, the past, but there might be something that we could learn from the history, as I've shown. And so I think it might be important to see the past event and what we learned in the past, because we could objectify the present situation as I have introduced in the presentation. So there is no comparison. We cannot objectify the present situation, but the past event and what we had in the past can be a kind of a reference for to look at the present situation. That one of the point I'd like to tell the student, and the importance of history is connected to the thing, or connected to the thought that we can objectify the present situation.
Right. All right. Thank you for your sharing. So it's mainly we have to learn from the past in order to move forward as well. So thank you, Dr. Morishita, for your time and for your presentation. I'll hand the time over back to Shu-Chen to close the session.
Thank you, Julian. Thank you, Dr. Morishita. So thank you so much for joining our April Prime session today. Let me do an announcement for our Asia Pacific Medical Education Conference before we close this session up. So as you all may have known, that our Asia Pacific Medical Education Conference 2026 will happen between 21st to 25th January 2026 in Yiwu, China. So the workshop symposium panel discussion proposal is closing soon. I do highly encourage all of you to submit your proposal before the closing date, which is 10th April 2025, in 3 days' time. So looking forward for your proposal submission. So thank you so much for 2 presentations today. We have a simulation in the beginning from the first speaker, and second speakers sharing about history in medical education using narrative. So both are very, I would say, a mind-blowing research that they are doing. Personally, I learned a lot. So I hope to see y'all to attend our next Prime session, which is happening in May, 5th May, from 12:30, same times, 12:30 to 1:30 Singapore time. And we do have 2 presentations, one from Taiwan and the other one from our Alice Lee Center for Nursing Studies, Singapore. So I do hope to see you next time. Thank you.